Hi, I'm Dr. Akana, and today we're going to be learning about beta blockers. So, a quick review about beta receptors. It's really important that you understand that there's a difference between beta 2 receptors and beta 1. Beta 2 receptors, if you remember from the other beta receptors video, when you see the number 2, you should be thinking that you have two lungs, so that's where beta 2 receptors come from. And beta 1, you should be thinking you have one heart. So the effect, if we are going to stimulate the beta 2 receptor, we're actually going to get vasodilation. However, remember we are talking about beta blockers, so the opposite's going to happen. So if we block the beta 2 receptor, we're actually going to cause the lungs to actually constrict. Whereas if we have a drug that targets the beta 1 receptor, we will be blocking the effect of the receptor, which means that we'll decrease the rate and force of contraction. We're going to decrease renin secretion, and we're going to decrease heart rate and blood pressure. So I'll say it again. So the beta 1 receptors work on the heart. If you had a beta 1 agonist, or if we were stimulating the effect of beta 1, these are the effects that we would have: increased rate and force of contraction, increased renin secretion, increase in heart rate and blood pressure. But because we're talking about beta blockers, we are going to block the beta 1 receptor, so the opposite is going to happen. We're actually going to lower the rate, and we're going to lower the force of contraction. We're going to decrease renin secretion, and we're going to decrease heart rate, which is really important to remember about beta blockers, while we are reducing blood pressure. So majority of the medications that we're going to talk about or cover in the hypertension section does not affect the heart rate. So it'll lower the blood pressure without directly affecting the heart rate. But beta blockers is one of those medications that you get both effects. So it's going to lower the blood pressure, but then we got to keep an eye on that heart rate because that'll be lowered or dropped as well. So let's get into it using this acronym NURSE MOD. N again stands for the name of drug, and I like to add the drug class. And depending if you need to know how the drug is formulated or how it is supplied. So when we're talking about beta blockers, we're actually talking about three different types of beta blockers. We have the selective beta blocker, the non-selective beta blocker, and we also have mixed alpha. So the selective beta blockers are atenolol, metoprolol. There are two different formulations. There is a tartrate and a succinate form. I will go over this in more detail in the heart failure section because these formulations do make a difference. And for the non-selective beta blocker, we have propranolol, and it comes in long-acting or extended release. And then also the mixed alpha and beta blocker, carvedilol or carvedilol phosphate. So that's that extended release. And also labetalol. So you can see that all of the beta blockers end in LOL. And if you set up a chart like this, it's much more easier to learn the generic name and the brand name. And then if you need to know, for example, if you're going to be working in the hospital or for nursing programs, a lot of the times you need to know which medications come in IV solution. So you can always write that here next to the drug name. You can make a separate column showing how the drug is supplied. And then also, always a good idea, go through your medications and highlight or make a note of which ones are the top 200 to 300 drugs. So U is for understanding how the drug works, or it's basically the mechanism of action. So selective, as the word says, it's selective, so it's only going to target specific receptors. The selective beta blocker will only selectively target beta 1. And remember, beta 1 receptors are located mainly in the cardiac muscles. So this is one that we want to choose if we want to just target just that heart. Non-selective beta blockers, we'll get into, why we use it, but there's several different uses for it because it's a non-selective beta blocker that gives us a couple of effects. It reduces chronotropic, inotropic, and also the vasodilator responses. The non-selective, or what we call the mixed alpha and beta blocker, will actually target alpha 1 and beta 1. So remembering that alpha 1 effect causes vasodilation, it'll reduce peripheral vascular resistance, but we'll get into it in the next coming slides that the alpha 1 is not just found or does not just have effects on the heart. It's actually found in several of the organs. So let's look at a visual so we can really understand and remember how beta blockers work. So if you have a beta-2 receptor, remember that you have two lungs. So the target organ where the beta-2 receptors are found are in the lungs. And if we stimulate it, we're going to cause vasodilation. But because we're talking about beta blockers, we're actually going to cause vasoconstriction. And this is something that we do not want to do if you have a patient that has asthma or COPD. You want to pick a beta blocker that is more selective and that's going to target receptors on the heart muscle. So remembering beta 1 receptors, the organ is mostly the heart, but it's also found in the kidneys. So if we stimulate the beta 1 receptor, we'll have these effects that we don't want. So that's an increase in heart rate, an increase in force of heart contraction, increase in renin secretion, what basically translates to an increase in heart rate and an increase in blood pressure. So when we're talking about beta blockers, what we want is the opposite of this, and we want to decrease all of these effects. Alpha 1 receptors, now this again causes vasodilation and smooth muscles in the blood vessels. We'll also see some reduction in peripheral vascular resistance, but they are also found in other organs such as the liver, the stomach. So it's not just lowering or causing vasodilation in the smooth muscle and the blood vessels that will affect the blood pressure. So this is going to have effect on other organs as well. And we'll go into this when we talk about the alpha 1 and alpha 2 drugs that are commonly used. So this is just a nice picture overview so you can really remember that beta 2, you have two lungs, beta 1, you have one heart, and remembering that the alpha 1 receptor effect is not just to lower blood pressure, there's not just cardiac benefits, but this alpha 1 receptor is found in several other organs. So you can expect that the side effects or even more benefits we'll see in other organs as well, because when we're targeting that receptor, we're going to target multiple different places. So this slide is just basically just to illustrate what happens when we do give a non-selective or a mixed beta blocker. So remember, your mixed beta blocker is your alpha and beta blocker. So this is a normal airway in someone that has asthma or COPD. So when they have an asthma attack, normally the wall is inflamed and it's thickened and it closes, so they have a hard time breathing. But when you have a beta blocker and we're causing vasoconstriction, we're actually causing this portion here. We're going to tighten that smooth muscle, so it's going to be very difficult for them to breathe, and it can actually exacerbate their asthma and their COPD. So reviewing what the drug is used for. So we all know that beta blockers are pretty much used for cardiovascular indications, so MI, angina, dysrhythmias, right? That makes sense because it lowers the heart rate, heart failure, and hypertension. But propranolol is also used for anxiety, It's used for GI hemorrhage, so it's nice to make a nice chart like this. That way, if there's any indication that is different, it's easily found and you can remember it. Just highlight, what the differences are if they belong to the same drug class, but they're used in different ways. So again, overall, we use this beta blockers mostly for cardiac indications, but the non-selective beta blocker, we do use it for other things as well. So S stands for side effects, but I also like to add in any important contraindications or warnings in this section as well. So it makes sense that because we are blocking the beta 1 receptor, we're decreasing the heart rate. So that will cause bradyarrhythmias, bradycardia, hypotension. The hyperglycemia is very minimal. The important thing to remember here is bradyarrhythmias, bradycardia, hypotension, especially when we're combining it with different medications. It does cause erectile dysfunction as well. And a common thing is a patient will report a feeling when they start this medication is they may feel cold, especially in the palms of their hands and feet. So the hyperglycemia actually is caused by a decrease in insulin production, but it's very, very minimal. So we really don't see a huge problem giving diabetics beta blockers. And we might see a transient increase in the blood sugar, but nothing where, we would not recommend giving a beta blocker to diabetic patients. Now, because it does cause bradyarrhythmias, it causes bradycardia, we do not want to give a beta blocker if they already have bradycardia, if they have sick sinus syndrome, if they have a heart block. And also, we want to be very cautious with combining this drug class with the calcium channel blockers, especially the non-DHP, which we'll go into the calcium channel blocker video, and then also I'll have a separate video on major drug-drug interactions that you need to be watching out for. So the warnings, we have to use this medication cautiously in diabetic patients, not because of that small hyperglycemia risk, but because it actually masks signs and symptoms of hypoglycemia. So typically, it'll mask the symptoms of shakiness, of heart palpitations, and people get really anxious when their blood sugar starts to drop. Well, they feel less of that, and the response to hypoglycemia is less when they do have diabetes. An important thing to note here is that we do not want our patients to just completely stop their beta blocker. What this will actually do, it'll actually cause life-threatening arrhythmias. It can actually cause hypertension, MI, and basically it's this withdrawal that they feel or that the body goes through, and from that withdrawal they'll have these life-threatening side effects. So now this is different. For example, if you're monitoring the patient's heart rate, and sometimes we have to stop the beta blocker if the heart rate drops below 50. And at that point, what we typically do, we back off on the dose, but we don't just completely stop them unless it's really necessary. If they're in the hospital, we got to stop the medication. They're in optimal conditions to be monitored in a hospital setting. We don't want them to just stop their beta blocker on their own at home. And if they are being treated as an outpatient, like I said, we typically back off on the dose. We lower the dose. And for some beta blockers, we give it twice a day. So for an example, what we might do is lower the dose and then gradually, over a couple of days or over a week, we might have them take it once a day instead of twice a day. That way we avoid this withdrawal syndrome that they go through. E stands for education. So you're pretty much going to talk to your patient about the side effects of the medication, things that they need to watch out for. So in patients with diabetes, you want to let them know, hey, if you've had low blood sugar in the past, this medication that we're giving you can actually change the way you feel when you have low blood sugar. So for example, if they had heart palpitations or if they felt shaky before, the medication will actually change or mask these symptoms. So they just need to be aware of that. You want to counsel them and review all of the other symptoms that they can experience with hypoglycemia, and just remembering to let them know of the ones that they may not feel anymore once they're on a beta blocker. Again, you don't want them to stop their medication abruptly. Explain to them what can happen and that the medication should be titrated down and then discontinued. And also let them know that, it is normal to feel that coldness in their hands and their feet. Educate them about bradycardia. Sometimes they have to monitor their own heart rate at home. And sometimes we give them, instructions to temporarily hold it and then call the provider if they notice that their heart rate is dropping, to below 50. And then also hypotension is important, especially if you are increasing the dose of this particular medication or if they are taking another medication that can lower the blood pressure as well. So M stands for monitoring, and I add in assessment as well here. So no matter what your indication is, if you are using this for hypertension, if you're using this for heart failure, if you're using a selective beta blocker, a non-selective beta blocker, it does not matter because they all lower the heart rate. So you want to monitor for bradycardia, and you want to hold this medication if the heart rate drops less than 50. So if you're giving this medication, for migraine prophylaxis, then you're going to want to monitor how patient is responding. If you're giving this for heart failure or angina, then you need to monitor for those specific outcomes. Now, O stands for outcomes, and because we're talking about medications used in high blood pressure, we're going to monitor and be sure that the medication is decreasing blood pressure without causing excessive side effects. So an example, we want to see a decrease in blood pressure, but we don't want that heart rate to drop too low. And then if you're giving it for other reasons as well, if they have some type of arrhythmias, if it's for migraine prophylaxis, then you would monitor that outcome as well. D stands for different, but I also add same in this acronym just because you want to go through, know the differences between the selective versus the non-selective versus the mixed alpha and beta blocker. And then when you have all this information in a chart or on your flashcards, you can easily pull them out, and then you can start to compare it to the other drug classes that are used for hypertension. So for this last acronym, I created a separate video, and it's just going to go over all the medications that we use for hypertension, and then you can pull out the specific key points. We can compare and contrast, what are the things that you need to know about those medications. So subscribe to learn more. I do upload videos weekly. I will cover all topics found in your pharmacology textbook. If you are struggling in a particular topic, or if you would like to see me talk about a certain topic, put a comment below and I'll be happy to do so. Thanks for watching, and I wish you the best.